This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients.
Welcome to the 22nd episode of PHM from Pittsburgh. I am your host, Dr. Tony Tarchichi. We are still coming to you from UPMC Children's Hospital of Pittsburgh. I am still a member of the Paul C. Gaffney Division of Pediatric Hospital Medicine. Today, we are here doing an episode on the very important topic. Thank you for joining us. The topic is breastfeeding. As a reminder, the University of Pittsburgh gives everybody free CME credit if you just click on the link at the bottom of the podcast, and you can answer some questions, get a free login, you can get CME credit for it. So without further ado, I'm going to introduce to you our very special guest who we're very happy and fortunate to have with us today. This is Dr. Jennifer Zarit. Dr. Zarit is an assistant professor of pediatrics at the University of Pittsburgh School of Medicine. She's an attending physician in the Division of General Academic Pediatrics in the Department of Pediatrics at UPMC Children's Hospital of Pittsburgh. She's a newborn hospitalist at UPMC McGee Women's Hospital. She's a 2011 graduate of the University of Pittsburgh School of Medicine. She completed her residency at UPMC Children's Hospital of Pittsburgh, went into private practice with a focus on breastfeeding medicine after that. She's been an international board certified lactation consultant since 2015 and was the interim medical director of the Breastfeeding Center of Pittsburgh prior to her returning and joining the faculty at the School of Medicine. She's an active clinician involved in medical education, director of the newborn rotation for pediatric and family medicine residents, as well as a director of newborn and lactation electives for residents and medical students. She's involved in the Allegheny County Breastfeeding Coalition and is the AAP Western Pennsylvania Breastfeeding Coordinator. And she lectures at the University of Pittsburgh School of Medicine on the medical importance of breastfeeding. So I couldn't think of a better guest to ask to come on. So Jen, thank you very much for joining us.
Thank you for having me, Tony.
So first thing we'll do, we have to, because we're CME credit by the University of Pittsburgh, we have to do our conflict of interest statement. So I'll go first. I have nothing to disclose.
I also have nothing to disclose.
Now, I'll start by saying this is a topic that's on our content specifications for our board examination for pediatric hospital medicine. So it's an important topic, and I think one that a few years ago was really stressed more, and now it's still stressed, but I don't feel as much in the medical literature. But Jen, why don't you tell us why this is such an important topic for us to talk about?
Well, I believe the majority of our listeners are pediatricians, and we're talking about babies, and a lot of pediatrics is feeding and growing our little ones. And I think in a lot of our training, we've learned basic questions to ask. How often has the baby fed? How long has the baby eaten? But beyond that, we really aren't given many skills to really be able to assess this. So if we just even go back to why we even care about this, if you think about it, human beings are mammals, right? And why do we get that name of mammals? It's because we have mammary glands. We were designed to be able to birth and feed our young. And way back when, if we didn't breastfeed our babies, they died. Or someone else would breastfeed them for us. And if you look at anthropologic literature and compare humans for how big they are, how long they take to develop, weaning age from a breastfeeder would actually be 4 to 7 years old, which seems, unbelievable in our day and age when we get into what our AAP recommendations are in a little bit. Part of the reason that it seems so crazy to us is that formula was developed. Now, I'm not knocking formula. It's really allowed a lot of babies to grow and survive that wouldn't have otherwise, but the popularity and the ease of use of formula has really diminished our overall understanding of the breastfeeding process. And so we need things like lectures and podcasts to be able to help our doctors really understand that process a little bit more.
So can I ask, you said either someone else would breastfeed or they breastfed. My family, my parents are Lebanese and they're from Lebanon, and my mom was from a very small village. She actually told me a story a few times about how my grandmother would nurse the babies from next door because that mother couldn't produce breast milk. And so my grandmother had 10 kids, and so she was able to. So she would bring them over and she would nurse them regularly. That kind of thing doesn't happen anymore, right? It's not as common as it used to be.
That's very interesting. Yes, actually, that was a very common practice prior to formula becoming very popular. It was called wet nursing. For some people, this was done on an informal basis, maybe like how your grandmother did it. For some women, this was actually their job. They would get paid to breastfeed babies of various families. And back when they had this as a career, they were limited to breastfeeding 6 babies at one time, which also just seems very difficult to do to me. But that used to happen on a more common basis.
6 babies at once?
Yep. That was their limit.
In one day?
In one day, every day.
Wow, that does seem like a lot.
I know. I don't know how that woman ever slept.
But has there been, before we get into the AAP guidelines and everything, has there been a backlash to our stressing breastfeeding in the lay community for women who just can't produce breast milk or for some reason can't breastfeed? I feel like there's been kind of I've had mothers tell me they're annoyed by it. There's a stigma to it now.
Absolutely. There's definitely been a backlash to the emphasis on breastfeeding, and I think that there are a lot of reasons for that. I think that sometimes the stress is put on moms to breastfeed, but the adequate supports are not there to help her do it. A lot of times the moms will say, yes, I want to breastfeed, and they're told, great, keep doing it, and just keep doing it more, and it will all work out because it's supposed to be a natural process. But as we know, as I've studied this more and as I've gotten more into the literature, although it's a natural process, that does not mean it's without its own obstacles. So what used to happen is, your friend, your mom, your sister, your aunt all helped you breastfeed and help get it right so that you were successful. And now, since we've lost that common knowledge, people give a lot of advice, a lot of well-meaning advice that may actually not be helpful to that mom in her breastfeeding process. And we have a lot of moms who struggle and think that they're doing it wrong, they must be a failure, and they just wanted to formula feed anyhow, so why try? So that's part of the problem. We definitely need much more support for these moms. We also have to consider 2 things as well. I think this gets lost in the debate as well. Number 1, we know that through the course of a lifetime, 1 in 4 women will be sexually assaulted. That, for some women, makes the breast area a no-go zone when it comes to babies breastfeeding. So whenever I get a mom who is very against trying to latch, I keep that in the back of my mind. A lot of these women will not express that these are her reasonings, but sometimes it can cause a trigger for her. So for those moms that say, nope, I don't want to latch, sometimes I will at least offer that expressing her breast milk is an option. But again, if she says that no, she doesn't want to do that either, then I just say, okay, you just let you know, we're here to help you if you ever change your mind, but I'm going to support you whichever way you go. That
makes total sense. I never thought of that, but that makes a lot of sense. If a woman was sexually assaulted, that could be a trigger. And you've read that in the literature that's been reported for people that's just something that prevents them from wanting to breastfeed.
For some women, yes. We never know who that's going to be because not all women that are sexually assaulted are going to have this be a trigger for them, but It's not something that comes out in the natural conversation with a new mom. The second thing I wanted us all to keep in mind, too, is being able to balance the mental health of the mom. If she is a new mom, she's sleep-deprived, number 1. She's recovering from pregnancy, number 2. Breastfeeding is really the best thing for her baby, but if she's very much struggling with this process and we don't have a lot of quick answers for her, going forward with breastfeeding exclusively may, for that woman, be damaging for her mental health. So we just have to be acknowledging of that. For some women, continuing breastfeeding is what they need to keep it together. For some women, decreasing the amount they're breastfeeding or stopping breastfeeding is what they need for their mental health. Again, these are not always things that come out in the natural conversation or things that the mom may even be parent to herself. As a quick anecdote, I had a friend who was dealing with some postpartum anxiety, and she attributed some of it to breastfeeding, and she had decided to quit. And she asked me for some advice on how to quit, and I respected her decision. I told her how to do it, and I think because I even gave her that allowance, that was okay, she actually decided to continue breastfeeding, and she exclusively breastfed for over 10 months. So I think sometimes just having the open conversation and knowing that we're allowed to make our own decisions can be helpful.
So anything else, just having that ability to do what you want is empowering.
Exactly.
Well, that's great. So why don't we talk about, since I know we have to know them and we should know them, the AAP breastfeeding guidelines.
Absolutely. Okay. So, number one, the AAP recommends breastfeeding unless there are certain contraindications, and we can get into those. But they do say we need to weigh the benefits of breastfeeding with the risks of not breastfeeding, because sometimes we also get lost in the benefits of breastfeeding, and we don't talk about the risks of formula. Now, in certain countries, sometimes they actually do talk about the risks of getting formula, taking all the benefits of breastfeeding and flipping them on their heads, saying, if you breastfeed, your baby is less likely to have ear infections, diarrhea, pneumonia. So if you give formula, your baby will actually have a higher risk of all of those things. However, again, sometimes because of different things going on medically with baby or mom, the benefits of breastfeeding do not outweigh those risks. The AAP also recommends exclusive breastfeeding for 6 months, and I was always confused of what that meant. So exclusive breastfeeding means nothing else in the kid's mouth, just breast milk. No water, no tea, no solid food yet. Okay. Then they say to introduce complementary foods around 6 months. And they want these to be iron-rich foods because this is about the time in the kid's life where they start losing the iron stores that mom had given them via the placenta. They do recommend breastfeeding for a whole year or beyond as long as mutually desired for mom and child. So if they wanted to go to 4 to 7 years, the AAP is okay with that.
Now, but there is still a stigma, I would think, in society. I don't know. I see people, whenever there's a mother with a toddler who's coming to nurse, people stare, people look. There is still a stigma associated with that socially. Am I correct in that?
In our country, absolutely. In other countries, it's more accepted, but you're absolutely right. In our country, that is a big stigma. Even seeing a mother breastfeeding an infant child is very stigmatized as well in our society. We want to say that it's not, but it very much is. And some of it is just needing to be exposed to this. In our society, we see breasts all the time. Victoria's Secret commercials, going to the beach, seeing women in bikinis. And we don't think anything of this. But if you see a part of a breast with a mom breastfeeding, suddenly it's taboo. But some of this, I think we just need exposure therapy too. Another quick anecdote, a city in the Midwest wanted to expose their residents to breastfeeding moms. So what they did is they got life-size cutouts of women breastfeeding their babies and placed them around town. Sitting on the bus stop, next to the gas station, near the library, and they just left them out for a few months, and they actually became a tourist attraction. People would come around and take pictures with the breastfeeding mom cutouts. So, and it was a way to just have it be a little bit more normalized.
I wonder if that worked.
Yeah, I don't really know. I heard that it was a little bit more accepted, but I don't know if it was just a running joke.
Yeah.
But I like the idea.
It's trying something. All right. So those are the guidelines then on what the AAP recommends. And I think the next step we have to talk about, what we could talk about is the absolute contraindications to breastfeeding, and then if there's relative contraindications, because that always, I think I did a prep question recently for this, that popped up.
Oh, that's a great topic. So there are very few true contraindications to breastfeeding. A few of them are, number one, in the Western world, HIV currently is one of those contraindications because here we have good water sources. Thus, they say that using formula is less risky than potentially getting HIV through the breast milk. This may change in the next 5 to 10 years, however, because they are currently doing studies with moms who are compliant with their ARTs and have a 0 to low viral load if they are safe to breastfeed. So
really?
keep up to date with that, yes.
Oh, wow.
Especially for those moms where at least they can be given the choice to breastfeed if they would like to.
Okay.
Active tuberculosis is a short-term contraindication to latching the baby at the breast. So say mom comes in to deliver and she's coughing up bloody sputum and they figure out that she has tuberculosis. They just don't want her to be near the baby, and having her latched at the breast puts her cough right on the baby. So they will quarantine the baby for 2 weeks, but she's allowed to pump her breast milk, and they can give that to baby separately. Herpes on the breast is another infection that is a contraindication to breastfeeding on that breast while the herpes lesion is open. You can still pump that breast to get the breast milk out. Most people would recommend dumping that milk because we don't know if it got in contact with the herpes. But once it's crusted over, you can again breastfeed back on that breast.
Okay.
Now, outside of infections, we do have inborn errors of metabolism, and there's only 2 that you have to worry about: galactosemia and tyrosemia. Okay. Interestingly, PKU you can breastfeed with. You just have to monitor the phenylalanine levels during the breastfeeding process, and they may have to add in the specialized formula occasionally if the levels are getting too high. But the majority, either exclusive or majority breastfeeding, can continue. And then the last category, we have infections, we have inborn errors of metabolism, and the last one is medications and drugs. So again, the vast majority of these are okay outside of chemo and radiation ablation of the thyroid. Chemo is bad because chemo goes after rapidly dividing cells, and that's what a baby's brain is made of, are rapidly dividing cells. But the vast majority of medicines are okay to breastfeed with, although some may be more preferred than others. There's a fantastic resource that I would love everybody to use called LactMed, LACTMED. It is run through the NIH. It's a free website, plus it's an app you can download on your phone, and you can put in any medicine, and it'll give you a nice summary of if that drug is okay to use while breastfeeding. And it gives you a summary, but also breakdowns of the research done on babies exposed to breast milk, what it does to mom's breast milk supply, any pharmacologic information that you need, and then also it's all resourced. So it's a fantastic resource if you don't know, because it's very common for moms to say, I'm on this medicine, is it okay to breastfeed my baby? And a lot of times out of an abundance of caution and not wanting to hurt the baby, well-meaning doctors will say, oh, just stop breastfeeding while you're on that medicine. And for some people, they may think that stopping breastfeeding for a 7 to 10 day course of antibiotic may not be harmful to mom. It could save the baby, but in actuality, not breastfeeding for a week for a mom can be detrimental.
LactMed, do you have to log in, or is that totally free to use?
It's totally free to use. If you can't remember LactMed, just say lactation, medication, and it should pop up for you.
I've never heard that. That's great. All right.
Yeah. So if you can remember those ones that are thought a lot of times to be contraindications for breastfeeding but are not, are things like hepatitis B, hepatitis C. You actually can breastfeed if moms have those infections. Mom being sick with a fever, actually that's the best time for her to breastfeed if she's able to, because she will be making antibodies to what is making her ill and can help protect the baby. Being prescribed methadone or Subutex, some people think that that is not okay either. In fact, that's actually preferred. If those are the only medicines that mom is using and no illicit drugs, we actually prefer that they breastfeed because it helps the baby with the withdrawal syndromes.
Oh.
Yes, it's very nice for them. Other things are if mom is pregnant, some doctors will tell her to wean, but that's not necessary. Receiving IV contrast for medical diagnostic test or anesthesia for surgery. The IV contrast is no problem. The anesthesia, a lot of women are told to pump and dump for 24 hours. When in actuality, a lot of times we're using propofol and inhalational anesthetics, and they come and go out of your system very quickly. So what I tell moms is if you feel like you could drive a car after anesthesia, go ahead and feed your baby. If you don't feel like you would drive a car, go ahead and if you need to pump because you're hurting, pump, dump that milk, and then feed the baby later on. And the biggest one that I want to stress here is antidepressants. A lot of moms are very happy, if they were depressed or anxious before pregnancy, are very happy that they stopped their antidepressants to get pregnant, and they don't want to go on them again. And they think that they can't go on them again if they're breastfeeding. So I love to tell moms, hey, if you had a history and you needed antidepressants before, guess what? You can use them and still breastfeed. And all the time I get very surprised, positive answers from moms. Oh, I didn't know that. So that's something we really want moms and doctors to know. There are ones that are more... Oh, sorry, go ahead.
No, I was going to ask you the same question. Are there any of the antidepressants we should worry more about?
Well, there are ones that are preferred. The preferred ones tend to be Zoloft and Celexa, but any of the other ones are still okay to breastfeed with if they've worked for mom in the past. Now, Prozac is one that's a little more long-acting, so I do watch those babies a little bit more closely, maybe with some more frequent weight checks, just to make sure that the baby is gaining appropriately as they transition during that first month of life.
Is that the side effect you would see is a child may not gain weight appropriately if they're being affected by the Prozac?
Great question. Yes, usually it's some lethargy, poor feeding. They could also be extra fussy with these types of medications. But more commonly, I see if it's going to be anything, it's going to be sort of being a little bit more sleepy, maybe not waking for feeds, or maybe not staying awake for the full feed.
Any other contraindications?
Well, if we are doing any illicit drugs, I would say no. So if mom's doing cocaine, that actually could kill the baby if she took cocaine and breastfed the baby, because it's in very high doses in the breast milk.
All right. The next thing that comes up, at least for me a lot in the hospital, is we get the baby coming in usually within the first week of life. They may have jaundice, they may not, or hyperbilirubinemia in the newborn, indirect hyperbilirubinemia. And the question is always moms are breastfeeding, and the question is, how is it going? So in terms of that interaction, or you have the baby that doesn't have hyperbilirubinemia, but is just not gaining or lost too much weight, where the pediatrician, the PCP is nervous, they send him in to be evaluated and observed. And now we have the baby and the mother. We have this mother who wants to breastfeed and seemingly having some trouble. Now, for our hospital, we don't have lactation consulting every day. Our NICU nurses got some sort of lactation certification, so they can help out. But what should I be looking for as a hospitalist evaluating this child, especially if I'm in a community hospital, let's say, without as much resources, and they're coming in for me to observe and make sure this kid's gaining appropriate weight? What am I looking for with the baby, with the mother, with the nursing, and when should I step in and say maybe we should supplement for a little?
That is a fantastic question, Tony, and that is exactly where a lot of people feel uncomfortable, where they don't think they have enough knowledge or experience to really be able to assess that. So first off, I would take a big overall view and say, what are our goals here when we're looking at the baby? You know, overall our goals are, number one, to make sure that the infant is hydrated and nourished. So making sure they're hydrated, making sure they are getting enough food to ultimately gain some weight. And then our second goal is also to help mom develop and protect her milk supply. So I think this is a scenario here where a lot of people would come in and say, oh, the baby's down 12%, they need some Billy Lights, breastfeeding's not working, let's just switch solely to formula. Not saying that that's what we want to do, but in the past I have noticed there was very little training on breastfeeding, and that was the go-to because definitely the baby would start gaining weight then. So starting off with the assessment to get to those goals of, number one, making sure the baby's adequately hydrated and nourished. You're going to start asking, taking a feeding history. So number one, is the baby feeding at the breast? So if they are, ask how often they're feeding. Now, a lot of parents know from the hospital they're supposed to feed them every 2 to 3 hours, so that's often the answer you get. Oh, every 2 to 3 hours. But this is where you have to take your history-taking skills to the next level and really, punch down through what is happening. So you can say, okay, every 2 to 3 hours. Is that from the start of a feed or the end of a feed? How many times in a 24-hour period do you think the baby is eating? You can ask, is this during the daytime and the nighttime? Are there any long sleep stretches here? And you'll be surprised by some of the answers you get. When I talk about the start to the start of the feeds, the reasoning for that is if you were to say the baby was feeding every 3 hours, but the count was started at the end of the feed, even if you're being conservative and say it only takes 30 minutes to breastfeed a baby, if you count that up over the course of a day, you will drop the feeds by 2. So instead of getting 8 feeds in a day, you'll actually accidentally give the baby 6 feeds in a day. So that's why that one is important. That's one of the most important questions you can ask is, when are you starting this timing? From the start of the feed or from the end of the feed? So not only frequency, but then you want to ask how long the baby's feeding. Is this one side of the breast, or are you doing both breasts? Are you having any pain with your latch? That is a huge question to ask because that is really, it's an objective marker for a very subjective question. How's breastfeeding going? They may say it's going fine, but then if you ask if they have any pain with the latch, they say, oh yes, it is so painful. But one of the well-meaning people in her life may be telling her that's the way it is. That's the way it goes. But we know that if mom's having pain with latch, this baby probably isn't transferring milk very well. After you get the feeding of the history at the breast, then we ask, are you doing anything else? Is the baby getting any other food, any supplement? Is that breast milk? Is it formula? How much? How often? And is mom doing any pumping of her own milk? And when is she doing that? Is that before a feed, during a feed? Some moms will do that, or right after a feed. And how much are you getting? So these are very important questions to ask from a very sleep-deprived mom that might not be able to tell you all of this in one go-round. That may have been a lot of information. Do you have any questions on that, Tony?
So after you've talked about the latch, one of the things I like to ask is the mother's sleeping and her diet and her water intake. From what I remember reading, a breastfeeding mother needs significantly more water to make the milk just to keep herself hydrated than a non-breastfeeding mother. Is that right?
Not necessarily. She does need a little bit more calorie intake than a non-breastfeeding mother. She will burn about 500 extra calories a day. However, we know from women who have been in famine areas that even if mom is not eating or drinking properly, that she can still make a full milk supply. That being said, we do want a healthy mom to have a healthy baby. So I do want to ask the moms, are you drinking? Are you eating? Are you going to the bathroom? The last thing we want is for a postpartum mom to get a UTI because she's so busy taking care of her baby that she doesn't take time for herself. So we want moms to be hydrated but not overly hydrated. I usually will tell moms, every time the baby drinks, you should drink some water too. It'll help with her fluid shifts that she's having in the postpartum period and will make her less fatigued as well.
In terms of positioning, Jen, that's always been a question mothers ask. And I remember before we had, my wife and I had our first child, we went and out of abundance of caution went and met with a lactation consultant beforehand, and they recommended almost like a perpendicular positioning, where the child is perpendicular to the mother's breast. Is that what you recommend, or is that mother-baby kind of specific? Each one's a little bit different.
It's a little mother-baby specific. Every baby is a little bit different, and every mom is a little bit different. One of the more preferred positions lately to help moms recover is actually one called a laid back position, where mom lays back at a 45-degree angle like she would be in a hospital bed, and you just put the baby skin to skin with mom right in the middle between her breasts and allows the baby to latch themselves. Sometimes you can guide them to one side, but the gravity of having baby flat on mom actually helps a lot with this positioning. Now, if this is not working organically and we need someone to help step in, a lot of times that perpendicular positioning really does help moms to be able to see what the baby is doing and to be able to assist them to latch a little bit more. However, if moms have had a C-section, sometimes that perpendicular positioning can be a little painful for their incision. So sometimes a football hold on the side, like tucking a football right under your arm, can be the most comfortable position for them.
Now this laid back, it almost sounds like mom could be in a lazy boy recliner kind of a thing.
Exactly like that.
And
that's what we hope, that it would be very relaxing for her.
And the baby's upright, laid right in between her breasts, and the baby can go left and right, depending upon, is that right? Am I picturing this right? Okay.
You're picturing it exactly right. And then her only job is to make sure the baby doesn't fall off.
That's not bad, yeah.
Yeah, and you can put some pillows under mom's elbows to make it a little bit more comfortable, and make sure mom's shoulders are a little relaxed so she doesn't get a lot of back pain.
So now, if I admit a child and a mother and we go through all this, and if it's something we can fix, let's say it's the positioning, and us or the lactation consulting group comes with the mom and helps with the positioning, and let's say that fixes the problem, great. But if it isn't, if there's dehydration and there's nothing improving, I usually will put the kid on formula and have the mother meet with an outpatient lactation consultant if she really wishes to breastfeed to help continue to work with her. And I'll tell her to try to pump so she can use express breast milk if she wants to do that. It's always person dependent. Is that what you would say is reasonable?
Yes, that often is reasonable. So you have to take the full picture in, not only the percentage weight down from birth, how many wet diapers are we having. Some people may remember that you want one wet diaper for every day of life up to about 6 days. So say we have a 4-day-old baby who's in the office or admitted to the hospital and they've only had 2 wet diapers in the last 24 hours, that absolutely would be signs of dehydration. You want the stools to change from that thick black meconium to more transitional stools by about day 4 to 5. And, is the baby waking up to feed? Is this an angry baby who's screaming his head off, or is he actually conserving energy by just going to sleep? Those are very difficult babies to breastfeed, and sometimes that's where formula becomes very helpful for those babies, or express breast milk, to give them the calories they need to actually wake up to eat. So you're absolutely right. If you wanted to help a mom both give adequate calories and hydration to her baby and support her milk supply, that's exactly what I would do. I would have her start by, working on latch and positioning, breastfeeding at the breast, and then having her or someone else give baby extra supplement while she pumps for about 10 to 15 minutes. And we can talk about that more if you'd like to. But usually that way we can give the baby breast milk and also extra calories, and then work on telling mom's body, hey, the baby's here and they need a little bit more milk from you.
Yeah, that's what we would normally have them try to breastfeed for 15 minutes, and then they can pump right after that. If they get anything out and they want to give that as a supplement, that's great. If they don't have any supply, then we use formula supplement, 1 or 2 ounces. If we don't think mom's producing enough, the child's obviously get dehydrated. Mm-hmm. And then we can let the mother, every time we let her nurse first, to hopefully increase her supply and get things moving along, get that oxytocin produced. But you said we could talk about
how to supplement.
Oh, yeah, let's do that.
So when you're going to supplement, a lot of times people go straight to the bottle, and that's not bad, especially if you have a sleepy baby that doesn't want to eat very well. Bottle is the absolute best way to get that baby to feed. It's not best way, but it's the easiest way to get that baby to feed. Now, there's a lot of talk about nipple confusion between breastfeeders and bottle feeders. And I think it may be more of a flow confusion, because when babies feed at the breast, you have this initial letdown with a little faster flow, and then it slows down and the baby has to work hard to get the milk into them. Now, if you have a bottle, it's very common to hold a baby more flat and hold the bottle more upright, perpendicular to the ground. And when the baby bites on the bottle nipple, this just comes flowing out at them, and they can gulp, 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 gulp just to keep themselves from being waterboarded. So sometimes then when we try to take them back to the breast, they got used to that fast flow, and now they're back at mom's breast. The flow's slower, and they're just fussy because it takes more work, and they just don't want to do that. So usually what I tell parents to do, if we're going to bottle feed the supplement, to hold them more upright, perpendicular to the ground, and to hold the bottle horizontal to the ground. This way, we can control the flow very easily. The baby's happy with that, we keep it there. If the baby needs a little bit more flow, we can tip the bottle upright a little bit more to help them. But this helps them transfer back and forth between mom a little bit easier.
In terms of nipple size for parents to buy for the bottles, would you recommend, if you're going to do this and this is a new mother or a brand new baby and they're just mom's getting started, to buy the slowest flow nipple size, like a preemie nipple or a 0 at least, to get that flow as slow as possible?
Yeah, that's a good idea. However, interestingly, there are no manufacturing guidelines on how to do the holes in the nipples. So you can take a preemie bottle nipple and a fast flow bottle nipple, and they may actually have the exact same flow between the two of them.
Really?
Yes.
So all those numbers that they make us look at is just nonsense?
Yes.
Oh, God.
They may actually believe they're doing that, but there's very little quality control. So that's why even if you have the slow flow nipple, controlling the flow by how you're positioning the bottle is still important.
Okay.
Now, there are other ways to supplement with cup feedings, where you put it almost in like a little medicine cup and tip it up to the baby's lips so that they can lick the milk like a little kitten drinking out of a saucer of milk. That is often very helpful for moms that want to completely avoid a bottle nipple at all. You can also syringe feed, which takes a little bit longer because you have to be able to squirt the milk in the baby's mouth. This can be done just with a syringe or through a feeding tube that you put on the parent's finger. This takes quite a bit of time to do, though. So if you're out of the first few days of life, this usually is not workable. But another great way to help supplement babies if you want to avoid bottle nipples is a supplemental nursing system. Now, this is essentially a feeding tube that you tape at the nipple that's connected to a bottle, either of formula or breast milk, that the baby will get extra flow of that supplement while they are breastfeeding from mom. This is, again, it's called a supplemental nursing system. This is not something I would expect any doctor to be able to do, but something that your friendly lactation consultant could help with.
Now, the cup idea, I have not heard of that, the little medicine cup. That seems like that would take a long time. Does it not?
It can take time to learn. Once parents are more comfortable with it, it is a lot faster than the syringe feeding, but not as fast as the bottle feeds.
Okay. And this is something I could recommend, but I could not explain how to do. This is where I would get a lactation consultant, and I would have them, if the family wishes that, show them how to do it.
Absolutely. Now, if we can get to the part where you, as a doctor, can say sometimes we call it triple feeding. We're going to feed at the breast, we're going to give the baby some supplement, and we're going to pump. And you can at least explain the holding them upright and using a bottle more horizontal. You have a big win for the day.
So why don't we talk about, because we're running low on time, and for those of you listening at home, we're going to make this a 2-part series on breastfeeding because there is a lot to talk about. We still haven't talked about premature babies and what do you do for those, and then we haven't talked about benefits to the mother and the baby. But why don't we'll do one more and get you out of here, Jen, and then we'll pick up another time, discuss the nutritional components of breast milk, because that's something that I feel like as pediatricians we should know.
Sure. Can I add one more thought about the increasing or working with a low milk supply mom?
Sure.
One other big point I just want to say is when we are pumping, a lot of moms will think that long breastfeeding sessions or long pumping sessions are better. But I actually want to say that frequency is our friend. So if we have frequent, short sessions, 10 to 15 minutes, it's much better than a long session. So 3 10-minute pumping sessions spread out in time is going to be much, much more effective for building a mom's milk supply than a long 30-minute session. So this will be mimicking a cluster feed that a baby would do to naturally build up mom's supply. So don't make her feel like she needs to pump for an hour to be able to get milk.
Okay. Short, more frequent, that's better.
Yes, absolutely.
So, Jen, if I wanted to counsel a mother for one reason or another who decided or has to stop breastfeeding for whatever reason, and she doesn't want to deal with the pain of the engorged breasts, what is a good way to counsel a mother to do that?
Sure, Tony. That's a great question. So one of the safest ways is just to have her go slowly about it. Take whatever she's breastfeeding now and drop one feed every few days. For some moms, especially if they did have a full supply, this can take a week or more to do. If they have a lower supply, it may only take a few days. But this is to avoid having engorgement, which can lead to mastitis or even an abscess in that breast. So this is really to try to save the mom pain and possibly infection.
Okay, and they drop one feed every few days until they're down to 0. The concern is otherwise it's pain and then could have infection. Is that right?
Correct. Now, if a mom does have a very full supply and she can't skip a feed without getting fully engorged, she could express some milk either by hand or by pumping just enough till she feels comfortable in between that skipped feed.
Okay. Well, that sounds reasonable.
And then you wanted to talk about the nutritional component.
Yeah.
Would you like to talk about formula versus breast milk or breast milk by different species? Because those are both interesting topics.
Why don't we start with breast milk versus formula? And then if we have time, we will get to the species.
Fantastic. Okay. So how is breast milk different from formula? Many ways. So we know most things have fat, protein, and glucose. So one thing we know about formula and human milk is that we do try to make formula to have a similar fat content to the breast milk. However, the formula is going to have a lot more saturated fat than the breast milk will. The breast milk will have more monounsaturated and polyunsaturated components of the fat. The protein content is similar between formula and breast milk. However, the type of protein is different. Most of the questions talk about the casein and whey ratios. If people can remember that C is for cow, is for casein, most formulas have a higher casein content in their protein than breast milk will. And if you can remember that W is for woman, is for whey, breast milk will have a higher whey ratio. So the question I've come across so many times will say long paragraph and then essentially what is the whey to casein ratio for formula to breast milk? And always the answer is going to be something in the range of 40 to 60 to 80 to 20. So we'll always have answer A will say 0 to 100. So you can scratch that. C will be 50-50. You can scratch that. And E will be the flip, 0 to 100, and you can flip that. So you're going to be left with two various ratios. And if you can just remember C is for casein, is for cow, that'll be your formula side. And W is for woman, is for whey, that'll be your breast milk side.
I like that. C for cow, W for woman. Sorry to interrupt.
Exactly. That's okay. Perfect. So the other thing that's interesting about breast milk versus formula is the same every time that you make it, but breast milk changes over time. I find it fairly fascinating because first, the breast milk that you make initially, that colostrum, that early milk, is made exactly for the gestational age of the baby. So if a mom has a preterm baby, say a 28-weeker, that initial milk is very different than if mom has a term 40-weeker. Somehow the body knows that the baby has different needs and will completely change the protein, fat, glucose ratio for that baby, and will also make it higher calorie content for the preterm baby.
That's amazing.
Yes, I know. And then the breast milk, as we know, changes over time. You have that initial colostrum, and then it changes to more mature milk later. But even within one meal, the breast milk that's in the front tends to have a lower fat content. It's more like skim milk in the beginning of the feed. Then near the end of the feed, it's much whiter and thicker, and that's more like cream at the end. So as the feed goes on, they start getting skim milk, then 2%, then whole milk, and then some cream at the end.
Oh.
Yes, so it's very interesting. So if you have a baby who is only feeding for very short periods of time, mom's only doing 1-2 on the first side and the second side, but then mom's pumping a lot of milk afterwards, the feeds baby's getting from the breast initially may have lower fat content, and then the pumped milk may have higher fat content. Very interesting.
So, and this isn't a 15-minute feed. They'll get all of the fat content, the lower and then the higher. But it's those who feed for like a short 2 or 3 or 4 minute period.
Yeah, it depends on the baby. If you are looking at a baby who's not gaining weight well, that might be something that you want to look at. They do this in the NICU occasionally, that if they want to really give higher fat milk to the infants, they will occasionally have these are for the exclusive pumping moms. Moms pump for certain volume and put that to the side, and then pump the second half of the milk to give that to the babies. But it's not always done. But it's interesting. If you ask any woman that pumps, they'll say the initial milk is almost clear, and then it gets much whiter as the rest of it goes on. Mm-hmm.
Okay. Anything else we need to know about the nutritional components of breast milk versus formula?
Well, there's also a lot of immunoglobulin and other infection-fighting factors in breast milk that are not in formula at all. So in our initial colostrum, you really get this huge load of IgA. If you remember back from medical school, IgA is the component that really coats mucosal surfaces. So if we can get babies to just even get colostrum, even if they get nothing else, that will help coat their gut for future infection fighting and also establishing a different gut microbiome than they would if they got formula. So this is really they call it sometimes the first vaccine, really is the first feed of breast milk. And we haven't gotten to gut microbiome at all because that would be a whole different discussion. But there's
been a lot of talk about gut microbiome in the recent past.
Absolutely. And so we know that if the first feed happens to be breast milk versus the first feed being formula, even if they go on to exclusively breastfeed for a year after that, those babies will have very different gut microbiomes, and you can never bend back to the initial microbiome of having all breast milk if you even had one formula feed in there.
Have we figured out so I know that we've learned that there is a difference in the gut microbiome, but what that difference can or does do for the child, I don't know that we've hammered out. Is that right?
Yes,
in terms
that's
of the
true.
Gut microbiome.
It's sort of I think the next great mystery, sort of in the 90s when we suddenly had the ability to do DNA sequencing. I think we're on the forefront of that right now, trying to figure out what that means. Now, overall, we know that breastfed babies have lower incidences of ear infections, pneumonia, diarrhea in the first year, but also things like IBD. They have less Crohn's and ulcerative colitis. They have less ALL, actual cancer. They have less incidence of it. They have less obesity, less type 1 and type 2 diabetes. And for the moms that breastfeed, they also have less diabetes, less hypertension, less obesity, and actually less breast cancer. So if we start thinking about our role as pediatricians in preventative medicine, instead of saying at the time that you're 10, oh, you're overweight, let's get on a diet and start exercising, exercising, maybe if we start from the very beginning and really helping our moms breastfeed with adequate supports for them, we may bend the curve on our obesity rates that we're having. Yet to be seen, but I think we could have a great impact.
We have just scratched the surface for potential benefits for mothers and infants in terms of breastfeeding. But I think we'll have to keep that for our next episode of this breastfeeding part 2. So if you're listening, there will be a breastfeeding part 2. Please keep a lookout for it, and we will get that information out to you, along with preterm or late preterm babies and what type of breastfeeding differences there could be if there are any. Jen, you are our guest. I'll be happy to let you get the final word. Is there anything you want to discuss that we talked about that we left out, or any final words?
Oh gosh, I could talk about this forever. But the only thing that I just want to really make sure everybody has is download that LactMed app. It will absolutely help you, either professionally or personally, when people call you to say, hey, you're the pediatrician, can I take Sudafed while breastfeeding? The answer is it's safe for baby, but it might impact your supply. So, and let's, just try to all get a little bit more comfortable with breastfeeding, and I think we'll all make a really big impact on all the moms and babies that we see.
Yeah, even as hospitalists, I have mothers that are sick, especially during flu season. They'll ask me these questions when I'm going from room to room, so that happens regularly. So it's good to know that there's that app. Absolutely. All right, we're going to bring it home. I want to thank our guest, Dr. Jennifer Zarit. Thank you very much, Jen, for joining us today. We really appreciate the talk. It was a great talk, and thank you for agreeing to come back.
Thank you, Tony. This was a lot of fun.
I'm glad. All right, now it's time for our acknowledgments. I would again like to thank our special guest for coming on the show. I would like to thank all of you for tuning in to PHM from Pittsburgh and letting us be a part of your day. I would like to thank, as always, the UPMC Children's Hospital of Pittsburgh, my division, the Paul C. Gaffney Division of Pediatric Hospital Medicine, for letting us do this. Of course, the University of Pittsburgh for their support and for the free CME credit to anyone listening. And as a reminder, the free CME credit is in the description of this episode on the podcast. Thank you, as always, to Dr. Megan Tarchichi, who helps me with everything. Hey, I hope you all have a great day, and we'll see you next time.